Okay, so what I want to do here is I want to explain all the sacral movements. And the sacrum, as I said, can be a little bit of a complicated bone. So this is the lower back, and this is that triangular bone that I was talking about called the sacrum. And this is our tailbone at the very end. Now, before we can correct any aspect of the lumbar spine, or even the whole upper back, and even up to the neck and head, the sacrum has to be in balance. Our center of gravity is at second sacral segment, so everything above that, in order for it to be in balance, this also needs to be in balance. Now, these two little areas here are called sacroiliac joints, or SI joints, and when you look at the back, it's those two little dimples just at the lower part of your back. Now, first we have to do is we have to make sure you don't have what's called an accessory SI joint. About 40% of the population has that. When they're jammed, no matter what you do with the sacrum, you cannot unstick it. An accessory SI joint just means that there's just a little extra facet. It can be unilateral or bilateral. So when I do an assessment, I can determine if you've got accessory SI joints that have been jammed. This is very common for anybody who's had a sports injury, you're playing contact sport, motor vehicle accident, so forth. So we unlock those. Now what we do is we have to, and this cannot be seen on an MRI or an X-ray, you actually have to do a mobility test. So what the sacrum can do is the sacrum can actually go down. It's called a descended sacrum. It can be both sides or it can be one side. This is very common if you've taken a knock to the head. It can be your forehead or the top of the head. And when you have a descended sacrum, the force when it hits the skull, either here or here, the force goes all the way down and it now causes the sacrum to drop. This can happen in infants, it can happen in adults. If you've taken a hard knock on the head, it actually does this bit of a trauma through the spine, causing the sacrum to drop. So what we have to do first is we have to make sure you don't have a descended sacrum. As you can imagine, that you have a covering around the brain and spinal cord, and then you've got an attachment down here at the sacrum. So when you've got any kind of a descended sacrum, it causes this drag. So all the nerve roots going down the legs are going to be affected. And when you have nerve roots being affected down in the legs, it can cause weakness in the legs. Maybe the knees aren't going to be strong. The ankles, toes, feet, all of that can have, they can collapse, they can toe in, they can toe out, because the muscles going into the legs are not strong. So now you've got an imbalance with the legs. So let's go back to sacral movement. So the sacrum can descend. It can also ascend, but not as common. So we have to check those. Is it unilateral, bilateral? The other thing that's important is that the sacrum actually moves through this axis of rotation. So it can either flex or it can extend. It can get stuck in those directions. Again, it can be bilateral or it happens only on one side. The next movement, and this one's critical because when people have a vertical axis rotation, where the sacrum moves this way or that way through this axis of rotation, these are the ones with debilitating back pain. And some of them can't even function at all. And this needs to be corrected. So again, it can be a vertical axis rotation where it's going this way. That definitely has to be corrected. The next one that we see is called an oblique axis of rotation. So now if we look at it this way, the sacrum can either move that way or that way. Same thing for this side. Sacrum can now either go this way or that way. So the vertical axis rotation has to be corrected. So what happens is when we do a mobility test, we look for each one, find the one that's most restricted, correct it. Of all the different axes of rotation that I talked about, you can actually have all of them in varying degrees. So we have to unstick it, check the movement again, find the next dysfunction, correct it, check it again. So once we get sacral positioning right, now we can start looking at the lumbar spine. This is L5, L4, L3. As most of you know, L4, L5 is the most common area where we get disc herniations. But they can also happen at L5, S1. But anyway, it can happen anywhere through here. Disc herniations in thoracic, not as common. Now we also get them in the lumbar spine. But even when we work with the lumbar, cervical spine, even when we work with the neck or the cervical spine, this has to be balanced because this determines the position of every single vertebra, and without balance here, and also the ilia, which I'm not going to go into right now, but these bones have to be corrected in order to work with a disc herniation.